Segmental spinal, the drugs used, indications and contraindications, ma'am. So segmental spinal usually refers to thoracic segmental spinal anesthesia. The thoracic segmental spinal anesthesia, it is typically used for patients undergoing surgery with major problems, medical problems where they are considered a greater risk for general anesthesia. General anesthesia is the standard for most of the surgeries, but however, some drawbacks can include negative drug side effects or prolonged recovery and inadequate pain control. In these conditions, we can use thoracic segmental spinal anesthesia. But usually anesthesiologists are hesitant to perform the spinal anesthesia above the termination of the conus medullaris because of the fear of injuring the spinal cord. However, thoracic spinal anesthesia, it is demonstrated to be safe and effective method for various surgeries, including laparoscopic cholecystectomy, breast cancer lumpectomies, and abdominal cancer surgeries. Giving thoracic spinal anesthesia may provide another option for these common surgeries, improve patient safety, reduce post-anesthesia care stay, and better post-operative pain relief. It is said to be one of the most upcoming technique. So moving on to the anatomy and the physiology, the anatomy of the thoracic and the lumbar regions of the spine is similar, but there are few distinct differences which are important to be understood. The anatomical studies have been performed using MRI to better define the space within the spine for the regional anesthesia. The MRI images have shown that the mid to lower thoracic segment of the cord lies anteriorly, where there is a CSF filled space between the dura and the cord. In contrast, the spinal cord and the cauda equina are touching the dura mater posteriorly in the lumbar region. As a result, there is a greater depth of posterior subarachnoid space in the thoracic spinal cord. And the space between the dura mater and the spinal cord in the thoracic spine is measured at 7.75 millimeter at T5 and 5.8 millimeter at T10. So the intrathecal injections at mid-thoracic levels have a minimum safe distance before the spinal needle contacts the spinal cord tissue. Next is the interlaminar spaces in the thoracic spine are narrow and more challenging to access with a needle due to overlap from the vertebral lamina. In contrast, the lamina of the lumbar vertebra do not overlap and the space between them is larger. And it is said for the spinous process of the thoracic vertebra is inferior, points inferiorly, whereas in lumbar vertebra, it points posteriorly. So this angled position of the thoracic spinal process will alter the angle of the needle if a midline approach is used. And so therefore, there's some difficulty can be encountered. And while performing thoracic segmental spinal, the layers of the anatomy transfers are the same as those in the lumbar, where the spinal anesthesia is traditionally performed. When the midline approach, the layers are skin, subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, arachnoid mater, and last the subarachnoid space. In the paramedian, it will be skin, subcutaneous fat, paraspinous muscle, ligamentum flavum, dura mater, subdural and arachnoid matter, and finally the subarachnoid space. That is, the ligaments will not be encountered. Anesthesia in the dermatomes. Further, since there is a less of a block of the lower extremities, a larger portion of the body does not experience venous dilatation, which may compensate for the adverse effects in the blood pressure intraoperatively. So moving on to the indications, thoracic segmental is currently best suited for select procedures and patient population. These include shorter procedures with patients considered high risk of perioperative morbidity and mortality, while under general anesthesia, patients unwilling to undergo general anesthesia, who are unstable to undergo the traditional method of spinal anesthesia in the lumbar region, and also at patients who tend to be older patients who decline in their physiological reserves, or when there are more of comorbidities. So, and one more is when in cases where you want to avoid polypharmacy, or when there's a cognitive dysfunction or frailty. Operations that have been performed with success include abdominal cancer surgeries, breast cancer surgeries, and laparoscopic cholecystectomy. Contraindications. There are major known The usual major contraindications to all the neuraxial anesthesia will include the same here. Absolute contraindications are patient refusal, lack of consent, local infection at the site of the procedure, or if there's any allergy to the drugs given, elevated intracranial pressure. In addition, the spinal anesthesia is also contraindicated when the operation is expected to take longer than the duration of the nerve block. Relative contraindication include when there is a pre-existing neurological diseases like multiple sclerosis or other demyelinating diseases, when there is a sepsis, severe hypovolemia, and coagulopathy. And also severe mitral and aortic stenosis, left ventricular outflow obstruction, like as with hypertrophic obstructive cardiomyopathy. So moving on to the equipment, it is the same like the spinal anesthesia where we'll perform it under an aseptic technique and the same sterile gloves and everything. BP blood pressure monitoring is a must. If required, if the patient is more comorbidities, then we'll perform usually using an arterial line. Routine monitoring is done and the spinal anesthesia kit is usually open, and the most important is here the drugs which is most commonly used are isobaric drugs are commonly used. So preparation and for the positioning of the patient history and physical examination should be performed before starting. The most important for patient history is allergies, prior adverse effects to the anesthetics, or any family history of complication with anesthetic should be. And also the physical examination of the thoracic spine is very important, and all the laboratory studies should be checked. And the setup for the procedure is patient positioning, which is performed either in the sitting or the lateral decubitus position. Sitting position is commonly favored because it avoids a potential rotation of the spine that can occur with the lateral decubitus position. The patient should flex the neck and push out the lower back to open up the thoracic intervertebral spaces. For lateral, the ideal positioning consists of having the patient's back in line with the edge of the bed, close to the anesthesiologist, with the patient's knees flexed up to their abdomen. Once the patient is positioned correctly, the insertion line is identified by palpation and use of anatomic landmarks to identify the corresponding spinous process. The space between the two palpable spinous processes is the site of entry. As always, the inferior angle of the scapula corresponds to T7 spinous process, and the 12th rib margin corresponds to L1 spinous process. These are the most commonly used landmarks in thoracic segmental spinal. Another approach is to use ultrasound guidance with counting up method, starting from the 12th rib and moving up until the corresponding vertebral level is found. The skin mark is then made to identify the correct level of the block. The skin of the puncture site should be infiltrated with 1% lignocaine in the midline or the paramedian location, depending upon the approach used. In the midline approach, the needle is angled more cephalad for thoracic segmental spinal, as the long thoracic spinous process point caudally and are most sharply angled between T4 to T9, making insertion of the needle in the midline more difficult in the mid-thoracic region. Beyond T10, they resemble like the lumbar region. And in the paramedian approach, the spinal needle is advanced at an angle towards the midline. And finally, we'll have a pop-out sensation that is when we have crossed the ligamentum flavum, as we do for the normal spinal anesthesia. So moving on to the complication, there are major and minor complications to the thoracic spinal blockade. However, major complication and serious complications are rare. Those include when there is a direct needle trauma, infection, vertebral canal hematoma, spinal cord ischemia, arachnoiditis, total spinal anesthesia, or a cardiovascular collapse or death. Minor complications include hypotension, nausea, vomiting, bradycardia, paresthesias, transient mild hearing impairment, backache, urinary retention. Last, even post-dural headache is also common. That's all, ma'am.
I mean, sir has come back. Okay, you presented quite well. And sir, morning, sir. Sir, good evening, sir.
Good evening. Morning for you there.
Okay. Yes, sir. I'm sir. 8 mani sir.
So I think they presented very nicely this segmental spinal. And I joined only from the portion where you started telling about the indications. What is the reason for selecting the thoracic region for segmental spinal, Anjali?
Sir, basically to avoid the complications of general anesthesia, it is done, sir.
No, that the technique is alternate to general anesthesia in supposed to be very sick patients. But why you
Yes, sir.
choose thoracic region for this so-called segmental spinal anesthesia?
Sir, the dermatomes which are depending upon the type of the surgery, sir.
Okay. No, segmental spinal means you don't want only those segments to be blocked. You don't want the
Yes,
other
sir.
segments unnecessarily like lumbar and sacral, all these
Yes,
things
sir.
will be spared in that, isn't it?
Yes, sir.
So patient will have good motor power in the lower limb, so there is no venous stasis like what happens in a lumbar or
Number. Yes, sir.
lower level block. Okay, so that is
Yes,
the
sir.
advantage. There is the calf muscle pump will be still working and venous return will be maintained. So that is the reason why patients do better with this segmental spinal. But my question is, why it is performed only in the thoracic region? Even though we do it for surgeries indicated in that, supposing you want to do a gastrectomy, can you do it with a thoracic segmental spinal?
So we'll have to cover a larger area, sir.
No, segmental spinal, can it be used for doing a very sick cancer patient who has a CA stomach? He needs a total gastrectomy. Can it be done by a segmental spinal? Question is this. I'm giving you a clinical scenario and asking you.
We can still do, but the
Yeah.
patient might require an additional cover, sir.
Blocked also.
Yes, sir.
But any anatomical reason why it will contain only, because if you give a lumbar spinal subarachnoid block, by tilting the
Yes, sir.
table and making the patient go head down to lumbar, you can sometimes, if the level is not adequate, we try that by giving a lumbar position. We want the drug to ascend up and then go and block a higher level. Even for cesarean, for example, you give only 2 ml and patient complains of pain in the epigastric region. Immediately you can
Yes,
give
sir.
a little head down tilt, and if the time has not elapsed too much before the fixation, it can spread up and go up to the dermatome what we require also. Whereas with thoracic, is it possible to adjust the level like that by tilting the patient?
No, sir. The drug usually settles.
It
Why?
gets locked. It gets locked.
What is the reason for that?
Curvature of the spine, sir.
Curvature of the spine, one. So it is more kyphotic, isn't it? So it likes a boat shape.
Yes, sir.
And what you give
Yes,
space
sir.
in that. Second thing is there is a small area between the dura and the bony canal. So there is an extra space where we can deposit the drug instead of completely going into the subarachnoid space. It will stay within that space. That is the advantage of segmental scaling, and it is possible only in the thoracic region. You can't give it. If you want to do only saddle, you can make the patient sit up and give a very small volume, make them sit up for quite some time, and then convert it into what is called saddle anesthesia. That is also a part of the segment of spinal. Okay? So it is thoracic, saddle, or hemispinal. All these things can be classified under segmental spinal anesthesia. You want to block only one limb for a diabetic patient who requires the above knee amputation. You don't want, he has got autonomic nervous disturbance. He is a known patient of autonomic neuropathy. By giving a lumbar spinal, if you block both the legs, he may not be able to maintain his blood pressure. He may have a severe crash in blood pressure and he may not respond to your normal vasopressors. So in that patient, by keeping the limb to be operated down and then giving a smaller volume of local anesthetic and remaining the patient in the same position for 5 to 10 minutes will block only that side of the leg. That is called hemispinal. Okay? So that also can be included in the what is called the segmental spinal anesthesia. Okay. So all the other points you have mentioned are quite correct for this answer. And what is the other part of the question? Minimum local anesthetic concentration. Is it? With MLAC? Anjali, are you able to hear me? Hello? Am I audible?
I'm not able to hear.
Not able to hear? Now?
Yes, sir.
Ah. What? I think it has got, the question has got two parts, isn't it?
No, sir. This question only one part, sir. MLAC in the second question, sir. That is post-operative analgesic management following radical mastectomy.
Okay, right. This is
She has completed
segmental
this
spinal
first question,
single
sir.
question. Okay, right.
Yes, sir.
So before going on to the next topic, I'll just show the PPTs for these two questions discussed by